My name is Daniel Luksic, and I'm the Medical Science Liaison at Natera's Organ Health Division. Today, I'm going to be presenting on a paper titled Identification of Disease-Causing Variants by Comprehensive Genetic Testing with Exome Sequencing in Adults with a Suspicion of Hereditary FSGS. This paper was written by researchers from the Technical University of Munich, and it was published in 2021 in the European Journal of Human Genetics. The study examines the positive diagnostic rate or yield of exome sequencing in select adult patients with FSGS or steroid-resistant nephrotic syndrome. The authors note that FSGS is one of the most common presentations of steroid-resistant nephrotic syndrome, along with minimal change disease. Over 50 genes have been implicated in causing these conditions, and previous studies have shown that the positive yield of exome sequencing in pediatric patients with these conditions is about 30%, but not much data is available on similar findings in the adult patients. This study seeks to identify variants in select adults with FSGS or SRNS. The study was conducted by screening 1,700 in-house patients for suspicion of hereditary FSGS. They used to include patients with a likely monogenic cause included family history, age of onset, and absence of secondary causes. For the patients selected after screening, exome sequencing was performed using next-generation sequencing technology and, where necessary, confirmation with Sanger sequencing. In one case, MUC1 analysis was added after exome sequencing came back negative in a highly suspicious patient. Variant classification was done according to ACMG guidelines, with an in-house database of over 16,000 exomes used, as well as ClinVar, for variant classification. Out of 1,700 patients screened, only 44 individuals from 19 families were selected for sequencing from the in-house cohort, plus 6 individuals sent in from outside partners. All told, 50 individuals from 24 families were sequenced. This resulted in positive findings in 7 of these families, meaning a total diagnostic yield of 29%. In 7 of the 23 index patients, a disease-causing variant could be identified. Here is a table of the results where you can see the index cases and their results. These variants were in 6 different genes, since 2 of the index cases had different variants in the same INF2 gene. A total of 8 different pathogenic variants were identified in these 7 patients, owing to 1 patient with 2 different variants in a recessive condition. There was not a significant difference found for the age of onset of disease or ESRD between patients who had a positive genetic finding and those who did not. For those with a positive finding, the time from the onset of the disease to the genetic diagnosis was a median of 9 years with a maximum of 37 years. This study found a very high rate of genetic findings in patients with FSGS. This is largely due to the stringent criteria used to select the patients for sequencing. Other large studies like Groupman, which had no criteria to screen out patients with a low likelihood of genetic etiologies, had a positive yield of about 7% in patients with glomerular disease. This illustrates the degree to which cohort selection and study design can impact genetic testing yield. Though there were strict criteria for which patients to test, which genes those patients had tested were very broad. In fact, whole exome sequencing was done and a wide range of findings came back. The authors noted that in 43% of the positive findings, the gene identified was outside of the initial suspected causative genes. This points towards the utility of a broad-based testing strategy and demonstrates that genetic conditions don't always present in the way we classically expect them to. This study was limited by the small sample size they used, owing to the strict inclusion criteria that was applied. The authors recognized that not all patients of the 1,700 initially screened had a thorough family or clinical history taken, which could have potentially ruled in many more patients to the study. The authors noted several examples of the benefit of this kind of testing. These included reducing the sometimes decades-long time from the onset of disease to the final genetic diagnosis which is sometimes called the Diagnostic Odyssey, and in which one patient had 37 years of wait. Ability to reduce contraindicated immunosuppression in patients with genetic FSGS also allows for a reduction in comorbidities. For some patients with the coenzyme Q10 disorders, there are effective drug therapies readily available and inexpensively issued. There are benefits in the form of evaluating donors who can be ruled in as a living related donor despite a family history of disease which may otherwise have excluded them. Further benefits of testing are to avoid unnecessary biopsies and allow families access to precise genetic counseling. Despite all of these benefits, genetic testing is not commonly used in patients with kidney disease. As the authors specify, this reluctance to use sequencing may relate to the lack of awareness of the burden of genetic causes on adult patients, which, as was demonstrated in this study, is not insignificant. Thank you very much for watching.